So, you know, I feel like that endometriosis is something that we can really start intervening much earlier. And so that's the message we've got to get out, is that painful periods are not normal. Get some education, and this is a pilot program she's doing, and we're having that research talked about at our conference, just to get another plug. She's going to be presenting there. And Rowley Sussex, Professor Rowley Sussex, is actually you won't know him over there, but he's a very well-renowned language person over here. He has a little show on the ABC once a week talking about words and language. It's fantastic. And he's going to be talking about the research he did with Susan on the language of pain. And you know, we all know our words are very powerful. So the language we as therapists use, you know, I feel like I mean, and I'm old now, I can say this, but, you know, sometimes we use words to make ourselves look a little bit more important. And so I think, you know, down training our words and our language and using simple language and caring words and thinking, what's the impact going to be of me saying that? Do I need to say that? Can I say that in a different way?
I think that's so important, Sue, because I think sometimes we can get bogged down. We get excited about things as well. I don't necessarily think it's always from a point of ego, but sometimes we do, you know, we want to talk about the periaqueductal gray matter, and, you know, we get excited. But I think, you know, it was Einstein who said that the true mark of a genius is if you can explain something complex to a 5-year-old. And to be able just to work with the person who's in front of you and meet them where they're at in terms of accessibility, but also then just making sure that they're hearing what you're saying. Not that it's all in your head or there's something wrong with your brain, but this is a normal reaction to an abnormal situation. And, you know, you are not broken, you know, but
definitely not broken. That's right.
Yeah,
what Carolyn uses some beautiful metaphors and ways of describing things. And one thing I really latched onto, and I use it all the time now, is that when we're 5, we learned how to do up our buttons on our shirt. And so we had to take a lot of concentration, and Mum was telling us what to do, and we had our tongue sticking out the side while we're trying to do it. And so then that physical act of doing up our buttons got mapped up here in our brain. Mm-hmm. And so we don't have to think about it anymore. We can do it, you know, while we're watching the news on TV and yelling at the kid to get ready for school. And it takes it's not in the front of our brain at all. It's mapped. It's very deep. It's a learned response. So if we continue to actually have an anxious, upper chest, panic-stricken breathing response to the fact that we think about it's going to be our period, or we've got to go and meet the family when we've got pelvic pain, or we've got to drive 3 hours to Dalby, then what happens is we have a new map. Our response is mapped that we're always going to stiffen, tighten, and breathe very shallowly. And so if we can remap in our brain what our response to that pain is going to be, then it stops going into that old fallback position, and we try to create some new responses, like sitting like a man, like belly breathing, like trying to do a body scan. And I have these little things that I've got printed. So we've got our little Zen frog here, and it says, the quieter you become, the more you can hear. And I have one of those on my desk all the time, to just, because, you know, I'm a naturally loud person, Michelle. And so when I'm with my pain patients, I am different. I'm trying to talk slowly and quietly and calmly. And the more they are ramped up, the slower I get and the quieter I get. So I'm trying to get them to mirror.
Those mirror neurons can kick in.
Yeah, trying to get those mirror neurons mirroring that they don't have to be, you know, like this. And it's really hard for them to change up what they've been practicing for a long time. Absolutely. And then on the back is the little body scan. What do we start up here, and let's just go through. And every time they're starting to get a bit hyped up, then we just go through a little body scan. And it literally, once you've taught belly breathing, I just go back here and I slump back and my belly's off. I say, let's just do it again. And so all the time in that treatment, I'm pulling them up and making them realize how they've got like this. And that's the thing. The key thing is to keep watching what they're doing and how they're responding. and bringing back the information that you want to get across, the key messages. So coming back to the manual therapy thing, you know, I'm very vagina-centric, Michelle. Having never been a manual therapy physio. In 43 years I've graduated, and I did 3 months in my first, you know, year of, and then I went into rehab, and I went into spinal injuries, and I went into intensive care, and then I've started in women's health. So I have no trouble not being manually therapy orientated. And until I started to do Carolyn's course, where, you know, she gave some very simple things to do. She's very focused, not focused, that's the wrong word, but she likes to integrate McKenzie work, where you're just doing a quick check of movements, extension, flexion, side flexion, just to look at those, do any of those movements. So you can go through the lumbar spine quickly, you can look at the thoracic spine, you can look and see, does anything provoke certain things, and you can do that, you know, just to quickly sort of eliminate that nothing else is going on. But, you know, I'm a manual therapist in the sense that when I come and examine a patient, I'm always got my hands very firmly, not in a creepy way, but a very firmly, I'm making them feel secure. I've gone through all that, gaining consent, and boy, is gaining consent in a pelvic pain patient who may have had an adverse childhood experience critical. And the critical part of it is not just to say thank you for your consent, but remember, you can withdraw that consent at any time if you are triggered by anything we're about to do. Yes. And so I think that's really important when we're coming to look at you know, what we're going to do with any internal examination. Carolyn does a lot of what we call ballooning and distracting of the skin. So she's doing some work like Diane Jacobs with dermo neuromodulation. So I really liked that. It's a little nebulous and a little, but, you know, patients respond to it because it's not threatening. So if you've got someone who is obviously going to be threatened by an internal examination, trying some of that work is really useful. Yeah. But I feel like it's letting go of the systems, you know, the systems that might be in your head about pain, yeah, and the all those things, and really start looking at what is the impact of psychology. Yes. So one of the other screening tests, of course, is the central sensitization score. And, you know, when you go through that and you get someone to fill that questionnaire in, and you get over a result of greater than 40 on that score. So I'm seeing someone at the moment who is had a terrible time with persistent pain, and she's got a lot of problems, and her central sensitization score was 76. So, you know, like, there's not much point in doing hands-on manual work with someone who is so sensitized, because virtually anything you do is going to really ramp her pain up. So it's really important. That's where I started doing these things, and it started to blow me out of the water, because, you know, it was really outrageously obvious, yeah, that this was central sensitization, and you've got to let go of the thing that there's something we're going to find to you know, fix this up. Yeah, I think that's a really key message, you know, Sue, that we can't just look at what's happening in her right puborectalis, you know, and is there a trigger point there that we need to release? Yep. And I think, you know, there is a role for sub-threat manual therapy to start calming down the nervous system and bring that brain towards a place of safety. But it's about working, it's about, again, like we said earlier, it's about meeting people where they are. And if someone has a 76 on a PCS, you know, where do you start, except by just creating a safe place for them to
to let them tell you their story, you know, without interrupting, which is the hard thing for us physios to do.
Very hard. But you have to, because, and that's another thing. I think that when you've got, you know, they say something and we always have an immediate answer. Like, I don't know about you, like anybody can say anything to me. And because of 43 years of problem solving and being a physio who I have to help everybody. So the milkman comes, stubs his toe, I'll have an answer for him. The important thing is that when you want to go and say something, just shut up, you know, and don't say anything and just see what happens.
Yeah.
Because sometimes it'll just, the next bit that they're going to say will blow you out of the water. And what you were going to say is really not going to help them.
Or even to ask them, what do they think they need? You know, what do you think you need? What do you think would help? And just to create that space, even for a better, you know, once they're at that point, for self-efficacy and empowering them to start charting their own path as well. Because I think sometimes we get into the habit of acting like a mechanic. Like you said, we want to swoop in with our cape and fix people. And I wonder if we...
so much.
Of course. We need to be transitioning towards maybe more of a coaching role. So what do you think would be helpful here? And what can we do to help you do that for yourself? You know, and it's really hard because I think particularly, I don't know, as women, as eldest children, you know, there's a whole lot of baggage, I think, for us as physios. I wonder, have they done any personality testing of physios? I'm sure that there must be some common traits like that, but we want to help people. We want to fix them. And sometimes the best way we can help people is just by allowing them to help themselves. And like you said, tell their story. So
I think that the thing is, sometimes when you've got 40,000 things in your toolbox, you know, and the older you get more and more collecting there. It is that we have to, our first step is that we've got to give the patient self-efficacy. We've got to actually come at this by saying, you know, my goal with you is that you walk out of here and you have a whole lot of things that you're going to do at home and by yourself, because I really don't want to see you in here every week or 3 times a week for me doing things to you. You've got to, I want to help you to be having self-efficacy. For a start, it's too expensive. And secondly, you've got to give them ownership, because otherwise, if you stop doing the things to them and they think the pain is being helped by the things you do to them, it's just going to come back because you haven't given them any self-efficacy. You haven't given them, they've got to own what's going on. And the other thing I often say to a patient when they leave, is there anything I've asked you to do that you're really saying in under your breath that you're not going to do that? Because I'd rather know now than you go out of here and think, well, she didn't really connect with me. She didn't really understand what I'm like, because why didn't she know I would never do that? So, you know, I always ask that as they leave, before they leave, so that I can say, you know what, that thing I said to you about, you know, try and go to the pool in the middle of winter and swim 3 laps because I think it might help your shoulder range of movement and your pelvic pain. You're not a swimmer. You'll never put your togs on. That was ridiculous. So I think it's also not imposing your own. I might like dance. Yeah. And I can tell you a lot of my patients get shown Instagram little short things, because, you know, the best thing that's come out of coronavirus, of the many, there have been many good things for us, Michelle, amazing things like transformed my practice. Like for a start, we've done videos for everybody instead of us demonstrating things. So much more useful, because the patient can look at it. They never remember. It'll be one thing they don't have to remember from us talking. And so the videos are all there for them to look at. So we just send them videos. The second thing is streaming our classes. The best thing that's ever happened. Because I don't care, like they're not make it a money-making venture, but I can give them away. I say, I'm going to give you this pain relaxation class we're doing on a Monday night, and I want you to just have a go, do it. Just sit and watch it if you don't think you can do it. Just sit and watch it and so you understand what it's about. And I don't care. Like, it means nothing whether, you know, 5 people are there or who are paying and, you know, 10 who are not paying. It's just, I want to get them, entice them into the idea that every class you do is not a Pilates class, that the classes you do are really about understanding about breath, understanding about stretching, understanding about doing a body scan to see which muscles are really switched on and which are not, and to acknowledge that there's a need for such a thing. So, you know, when we talk about movement and exercise, like, it's really important to do exercise and move when you have persistent pain. But you know somebody, and I know plenty, who, and I'm not pointing the finger at anyone we know, I'm just saying everyone knows someone who overdoes exercise because they're very stressed in their life. And so they're working out, and that's not good for your immune system either. So you get a negative response in your immune system if you overtrain.
Yeah, for sure.
And so, you know, getting balance with exercise is really important, like doing some yoga, which I know you love, and you know, things that are calming down training. Tai Chi is beautiful, and as you said, dance is beautiful because it's a lovely movement. And, you know, if we're going to talk about glossing and flossing nerves, you know, there's nothing better than doing a little bit of dance to do that. And so, you know, I think that those messages are really important.
And I think as well, though, you know, if we can find a movement that the person enjoys, first of all, they're more likely to do it. But I think it reinforces that message because of learning to trust your body again. Because I think sometimes for a lot of persistent pain sufferers, there can be a lot of anger and a sense of betrayal towards their own bodies. And to learn to make peace with your body again, and to trust it, and to get back into your body in a way that you actually enjoy, can be a huge turning point on the road to recovery. And not necessarily that recovery means that you're going to be 100% pain-free, but that you learn to live your life and to manage and to find joy, you know, where you can.
Yes.
You know, it's so important.
Yeah. Well, one of the other screening sheets that we give out a lot now is the Injustice Experience Questionnaire, the IEQ.
Okay.
And just one of the patients that I just want to bring into this conversation was someone who'd had 10 surgeries for a missed fistula. And so she'd had mesh repair, she'd had a whole lot of stuff done. And so finally she got to see, you know, Professor Judith go up here, who found the problem and repaired it finally. And because I was thick in the middle of Carolyn's course, I just gave, and she was from Sydney. She saw, you know, found me and wanted to see me from Sydney. So we'd made this appointment, and thanks to coronavirus, we were getting stumped all the time. And I said, look, let's stop doing this. Let's just do a telehealth, because telehealth is brilliant and it works really well. Let's get started. Let's learn what we can on telehealth. So we're going to break this down and we'll get to do the examination. But, you know, it's really the lowest part of this food chain of information. The information, the education, and I told her that 1 in 4 women it will get 50% improvement from simply pain education.
Yeah.
Now, you know, I gave her everything, and her injustice score was through the roof. She was so angry about what had gone on, but she was a gorgeous person. Like I'd have been, you know, she was lovely. She didn't do that. She did that score, and I said to her, your injustice score is through the roof here. Do you have a look at what you rated yourself? Carolyn's got this great way of saying, if you've got a tricky thing to say to a patient, you keep reminding them they filled the questionnaire out. You didn't do it. They did it. Look at how you rated yourself. And, you know, with the injustice score, if you've got a score higher than 30, you've got a severe risk of ongoing disability at 1 year post-injury. So the research tells us that you have when these injuries happen, you have a prolonged effect on your life. So, and anyway, she just she literally did weep because she realized, and she'd never really thought about it, that she was so angry about it all. And I said, and Carolyn pointed out a book, and I've just forgotten the name, but it's something about forgiveness, and I've got it here somewhere. And I will tell everyone, because it is, I think, a really important thing to be able to give patients. Forgiveness, forgive for good. Oh. You know, because there's really nothing, and it's by Dr. Fred Luskin. There's nothing that is going to be gained by and that's the problem with all the mesh litigation. When a patient comes in here and they're a part of the mesh court case, I say, you don't have to be suffering pain to get whatever is going to happen from this. I said, we're going to make you better. Do not think you have to linger on, because that's what sometimes they, you know, it's not a front of mind thing, it's a back of mind thing. I've gone through all this pain and suffering, and if I have no pain and suffering when I'm judged, I said, it's all documented. You do not have to let it go, move forward, and forgiveness is part of the moving forward thing. So that I would, you know, just having an objective figure to give her and show her, and it brought to her attention. And then we started to work on strategies to deal with that anger. And she, I saw her right at the beginning of the pandemic on telehealth. I got to see her once up here. She came up, drove up to Sydney to see me. Wow. We did two visits, because she's got had a place at the coast, came up twice, and all her pain was amazingly better. Now, she was still very incontinent, and so she had urinary leakage as well, because the mesh had to come out. And so there's more to be done, and unfortunately the borders have closed again. But, you know, that's what is important, is being able to then tease apart what is actually the important thing, rather than just thinking it's all about, I've just got to tell this patient it's all in your sensory brain map. Like, it's not all about that. And that's a little bit what we were doing quite strongly before. And that's why, you know, it is that thing that I'll know I'm dead when I stop picking up you know, an article and looking at it, because even if I'm 95, and one of my mentors, you know, from a long time ago is Shirley, and God help me, I'm going to forget her last name. Shirley, that's terrible.
Shirley Owens?
Shirley Owens, thank you, Michelle. Shirley Owens is 90 something or other, and she still keeps in contact with us, and she is so engaged with the profession, and she is so engaged with trying to keep up to date, and she loves seeing things I've written. She likes reading my blogs. And, you know, I want to be Shirley Owens when I'm 95. I want to be engaged. I want to be still up to date, even if I'm not actively involved with patients, because I think it's important for our brains to keep doing that ongoing learning. And, you know, what's really important is to let go of stuff you paid good money for a long time ago at a course, and it sounded really cool at that time, but just let it go, because we're moving forward with what we know about the brain, psychology, pain, trauma, and, you know, how the body reflects all of that stuff.
Absolutely. So I cannot thank you enough for spending all this time sharing what's going on in your brain, because that was just, I think it was a really valuable conversation that will help, I think, a lot of women, obviously, but I think it will help a lot of clinicians, of healthcare professionals working with women in pain. And I think one of the takeaways is that, first of all, we don't have to fix everything, that listening is a really important part of what we need to do. And I think, you know, the judicious use of measures like the Tampa Kinesiophobia scale, the PCS, and the injustice exposure measure?
No, the IEQ is the injustice inequality. Injustice experience questionnaire. Injustice experience questionnaire, yeah.
I think,
and DAS, and depression anxiety scale is good.
Absolutely.
And the other one is that did you mention the central sensitization score, CSI? Yeah.
I think, you know, what we're not saying that we want to be psychologists, but everything that we have to do needs to be psychologically informed, because we are working with whole people with histories and stories. So can you just give a shout out to where people can find your blogs and your books, of which I am a fan?
Thank you, Michelle. My books, I have a website which is called pelvicfloorrecovery.com, and you can purchase them directly from there. We ship all around the world. So we also, the beautiful Fiona Rogers has them on her pelvic floor exercise site. And also my blog, and we're up to about I'm up to about 330 blogs now. And so there's a lot on pelvic pain there, and they're grouped under a one big one of all pain resources in one area, but there's also quite a few that are scattered through. There's also a little bit of Italy on there, so if you're longing for some photos of Italy, there's plenty of trips that we think memorably and longingly about, and hope one day we'll get back there and do it again. But so yeah, I encourage everyone, so just Google Sue Croft blog and it should come up. And yeah, so look, thank you very much for the opportunity to have a chat, and to invite me to even talk with you is always wonderful, Michelle.
It's always a pleasure. And just on a personal note, before we sign off, I was talking to Morgan in the kitchen before I came down, and on my first teaching trip to Australia, Morgan came with me, and you very kindly made her a birthday cake for her 15th birthday and had a little gathering at your house, and we still talk about that. So she wanted me to say hello and thank you for that.
It was lovely to see her.
I want to thank you for all
and to do that
for the world, though, of women's health, because I think you have been a tireless advocate, and I think an example to all of us elder lemons who have been around for a while, in that you are constantly evolving and learning. And I think that's a shining example to the rest of us. So thank you very much for all that you do, Miss Sue Croft.
Thank you, Miss Michelle Lyons. And everything you do as well. It's it's beautiful and lovely and it's so lovely we can communicate across the world. And look, you could be next door and we could be doing this, because of what's going on. So, and I think, look, I feel there's just one more thing, like, it is such a crazy time, and I don't know about you, but our patient load, everybody is very anxious and very worried, and their pain levels are through the roof, and it's escalating. And I think that, one of the messages I want to get here, like, you just have to see this as the new normal. Like, this is going to be like this for a while, and it's like you're fighting the system. It's easier to go with it, to try and follow the rules. Rules are good in this sort of environment because they give us some structure, and that helps with anxiety, to have some structure. And to all those things we do for pain, we do, like keeping on exercising, finding some nature, even if it's the backyard, if you're not allowed out far away from your home because of lockdown, but trying to bring nature, trying to look at funny photos or lovely memories from photos, and doing all those things to really make our brain, that happy part of our brain, flourish, because it's too easy to get dragged down with these terrible times that are happening now. So yeah, everyone take care and be safe.
Absolutely. As Beth Darnell would say, go on pleasure hunts throughout the day. Sue, thanks a lot. And everybody check out Sue's blogs, because really I think they are a really easily accessible path to implementing good science into your practice. Bye for now, and thank you all for watching.